Online.
Yeah. Good evening, everyone. I welcome you all for today's webinar on Meet the Experts on Oncology Treatment Update 2024. With immense pleasure, I would like to invite Dr. Ulfatara, who is Associate Professor, Department Medical Oncology at Sher-e Kashmir Institute of Medical Sciences, JNK, Dr. Aditya Alihans, Medical Oncologist at Chandan Hospital, Lucknow, Dr. Abhishek Bansal, Consultant Medical Oncologist at SSB Hospital, Faridabad, Dr. Ankur Nandan Varshne, Consultant Medical Oncology at Medanta, the Med City, Gurugram. And I would request Dr. Ankur to deliver his first talk. Over to you, sir.
Hello,
Yes, sir. Can we share Dr.
hello.
Ankur's slide? Yes, sir. You are audible.
Yes, I'm sharing.
Can you please share? Okay.
Yes, sir. Yes, sure.
Are the slides visible?
Yes, Varangi, it is
Yes,
visible.
slides are visible. Oh, hello. Hi, good evening, everyone. And the first session today is regarding advanced EGFR mutated NSCLC treatment, a review of targeted therapies. So we move with the next slide. Next slide. So coming to the incidence of lung cancer, we are still going with the Globocon 2020 data. And what we know, it's the second most common cancer diagnosed in males and third most in females. We still we need to move to the previous slide. Despite being a lower incidence as compared to the breast cancer, the mortality in the lung cancer is more, and it's the number one cause of cancer-related mortality in males and number two in females. In India, we have lung cancer as the four most common cancer related because of cancer-related deaths, and fourth most common cancer as per the incidence. Out of these, our epidemiology is rapidly changing. In the initial time, it was the squamous cell cancer, which used to be number most common pattern of lung cancer. But these days, various of the studies have suggested that non-small cell lung cancer combining is, especially adenocarcinoma, is the most common cause of lung cancer. Next slide. Next slide. So this slide clear cut shows the presentation. Unfortunately, majority of our patients, approximately 65%, present in stage 4 when this cancer has already spread to other organs. Only 1% of patients are being diagnosed in stage 1, and these are usually those patients who presented with some other symptoms or underwent a screening test and got diagnosed with lung cancer. Approximately 4% of patients present in stage 2. So we see only 5% of patients present as in surgically resectable stage, and in majority of patients are in stage 4, and this is followed by stage 3, where approximately 30% of our patient population are diagnosed with stage 3. Next slide. So as majority of patients presenting in advanced stage, we have the limited treatment options, and with this we need further treatment options which are more than the traditional aspects of chemotherapy. And we see that approximately more than 50% of these patients, especially the patients who are female, who are non-smokers, have presence of biomarkers. These predictive biomarkers are having therapeutic efficacy, and if we analyze them, then approximately 17% of these patient population worldwide have a presence of EGFR mutation. Approximately 8% have ALK rearrangements. Then there are various KRAS mutation and other mutation also. which play a significant role. Luckily, in Asian population, there is a more increased incidence of EGFR mutation, and various studies have reported that this EGFR incidence varies from approximately around 30%. Next slide. So what are the testing methods we can analyze? We can analyze EGFR through PCR-based assays. Regarding, we can definitely analyze ELK. We usually have a preferred route of, we usually prefer ISC in ELK and Roche, but confirmatory, it's through a FISH method, which is gold standard for the comparison. And in PDL1 testing, which is usually for the immunotherapy status, we go with the ISC levels. Next slide. So we discussed that there are various EGFR driver mutations, and these are the exons study analysis which we study. The most common in our setup is again exon 21 mutation, L858R, and the followed by exon 19 deletions, which shows a quite unique drug sensitivity to EGFR tyrosine kinase inhibitors. Next slide. Now, as I discussed earlier, that Asian population has a more significant prevalence of EGFR mutations. And if we see this data again, then definitely Asia had an increased prevalence of a stage 4 disease as compared to the Western world. And this the useful thing with these EGFR TKIs are available and can be used for the treatment of patients with lung cancer. Next slide. So definitely NCCN recommend molecular testing of EGFR either through a PCR-based analysis or in either NGS-based analysis in both early stage and in advanced stage, NSLT. Next slide. So we already know, we have used it, and we are have an experience of over half a decade, that osimertinib is a third generation tyrosine kinase inhibitor, which is active in CNS disease also, and have been active for EGFR exon 19 deletion mutation and T790M resistance mutation. The pathway is clearly shown, and this drug is a third generation tyrosine inhibitor when it inhibit both the mutation pathways. Next slide. So how any scientific data is always needed to support a drug, and for this the osimertinib, we have a FLORA study, which is a phase 3 study to study the safety and efficacy of osimertinib versus the previous standard of care as first-line treatment in patients with locally advanced or metastatic NSCLC, which are harboring EGFR mutations. Next slide. So this is a phase 3 study where patients who are more than 18 years having exon 19 deletion status with stable CNS mets were allowed either to receive osimertinib at a dose of 80 mg or EGFR TKI, which was the standard of care at that time, which was gefitinib or erlotinib. The primary endpoint of this study was the PFS, and secondary endpoint was overall response rate and overall survival. Next slide. So definitely comparing to the baseline characteristic, definitely in majority of these trial, majority of patients were female, median age was 64. And if we see the Asian population, then they were predominant. Approximately 62% patients were Asian. Approximately 35% were never a smoker and 65% were a smoker. CNS mets were present in approximately 20% of the patients, and EGFR mutation 19 deletion was common, representing approximately 60% of patient population, while L858R was present in approximately 40% of patient population. Next slide. So these curves are known to us, and this clearly established osimertinib as a main treatment and category 1 NCCN recommendation, with these Kaplan-Meier curves showing a median PFS with the use of osimertinib to be reported as 18.9 months, while the standard of care arm with the erlotinib and geftinib, the median PFS benefit was limited to 10.2 months only. So with the use of osimertinib, risk of progression or death is reduced by 54% as compared to the ongoing standard of care. Next slide. The main advantage in this is lie in this plot. If we analyze, then we see the advantage of osimertinib in all the subgroups, especially the patients who have CNS mets. This osimertinib shows good benefit, and patients who are non-smokers. So we see, especially in all the patient populations, osimertinib is favored over standard of care, irrespective of the age, irrespective of the smoking status, irrespective of the type of mutation. Next slide. Coming to the response rate, we can see these curves. Definitely, osimertinib is having a more response rates as compared to the existing standard of care. And if we see this duration of response, definitely the use of osimertinib, duration of response is 17.2 months, which is around more than double than the standard of care, which is only 8.5 months. Next slide. So this is a more advantageous chart, and where we see that at the end of this study, the osimertinib is a drug which have shown a or overall survival benefit. The use of osimertinib, median OS was reported to be 38 months, while in EGFR TKI arm, the OS was reported to be 31 months. And this was the fact that a crossover in this trial was allowed. So we see that the use of osimertinib, we have a definitely significant overall survival benefit of around 8 months. Next slide. If we see the the adverse event, then this drug is fairly tolerable. The prominent side effects include diarrhea, which is present in approximately 60% of patient population, but rarely it is grade 3 or 4 on only 3% of patient population. Another side effect is the presence of rashes, and this again is usually grade 1 or 2 and present in approximately 60% of patient population, while grade 3 or 4 rash is already only present in only 1% of patient population. The other side effects which are quite common is nail changes, dry skin, anorexia, cough, LFT derangement, and these side effects are quite comparable with the TKI standard of care. And if we see, then numerically there is advantage in the osimertinib cohort, which has a lesser side effects. Next slide. So the most important is CNS efficacy, and definitely osimertinib resulted in highly significant and clinical meaningful improvement in PFS, and especially we have a clear-cut advantage in the CNS PFS in patients who have brain mets. The final result analysis of overall survival gives an edge of osimertinib over other TKI inhibitors, and we have a safety analysis where this drug is fairly tolerable. So osimertinib is established as a standard of care for first-line therapy in patients with EGFR mutation in advanced non-small cell lung cancer. Next slide. Next. So we are discussing about the CNS efficacy of osimertinib. Next slide. So if we see the benefit in patients with CNS mets, the median PFS reported with osimertinib was 15.2 months compared to standard of care, which was only 9.6 months. If we see in the patients who were not there with any CNS mets, so the PFS reported with osimertinib was 19.1 months, and with the standard of care, it was 10.1 months. So irrespective of the patient presence of brain mets or not, osimertinib provided benefit in both the cohorts, and this drug has shown CNS activity, which was not quite shown in the drugs such as erlotinib and geftinib. Next slide. If we see the PFS benefit in the osimertinib cohort, it was not reported after a median follow-up of 12.4 months, while in standard of care cohort, after a median follow-up of 7 months, median CNS PFS was reported only 13.9 months. In this, we saw the charts which were quite separated at the end. So definitely the patient who have CNS met continue to do good with the use of osimertinib. Next slide. So coming to the osimertinib comparison with the second generation TKI such as decometinib. Next slide. So this is a PFS comparison with the use of decometinib and deftinib. We don't have a direct comparison of osimertinib with decometinib, so we are comparing the trial data of Archer 1050 and Flora study. PFS benefit of 14.7 months versus deftinib, which reported a PFS benefit of 9.2 months. So we have an advantage of around 6 months. If we see this difference, osimertinib versus deftinib, we have an advantage of around 8 months benefit. And if we look at the charts, these Kaplan-Meier survival curves, and the separation of curves in the Archer 1050 arm occurred at the interval of 6 months, while in Flora trial, the separation of curves started at earlier with the onset of treatment. Next slide. So we can conclude that this drug osimertinib is a faster acting and have a sustained response. Coming to the overall survival data. So overall survival data in the Archer 1050 study was not reached, and we have the decometinib, the median OS reported was 41 months, and with the use of geftinib, median OS reported was 33 months. And this difference at the end of this study was not found to be statistically significant as compared to the Flora study, where the benefit of overall survival was found to be statistically significant. Next slide. So we have already discussed this Flora, where we have a clinically statistically significant median overall survival benefit. Next slide. Next slide. So if we study this overall survival benefit of osimertinib, then definitely we have a specific this plot shows, or this plot shows, the benefit is usually recommended in all the subgroups, especially the patient population. It is irrespective of the male or female presence. More is profound in the patients who are having CNS mets, and slightly more pronounced in patients with who have exon 19 deletion. Next slide. So if we study there was this plot analysis for the Archer 1050 study, then we definitely have the patients who have if more pronounced performance status, or in the patient population who have exon 19 deletion, this drug was quite less effective as compared to the geftinib arm. Next slide. Coming to the discussion of osimertinib versus another TKI, which is afatinib. Next slide. So afatinib was studied in the Lux study, and the PFS benefit of reported with this afatinib was 11 months, which is numerically more, but we don't have a clinically significant benefit. And approximately the comparative arm was again geftinib, which reported a median PFS of 10.9 months. At the end of 24 months, we have approximately 17% of patients surviving in the afatinib arm and only 7% of patients surviving in the geftinib arm. So this difference was not to be found to be statistically significant as compared to the Flora study, where osimertinib had reported a median PFS benefit of 18.9 months. And the final overall survival analysis was not done. This data was insufficient for the analysis of afatinib overall survival data. Next slide. So coming to the OS data from the the Lux 7 trial, and we see that the graphs doesn't separate much, only a numerical endpoint survival. We have a marginal benefit with the use of Eftinib, where median OS reach was 27.9 months versus Jeftinib, where survival was only 24 months. This difference was again not found to be statistically significant. Next slide. If we compare the safety analysis, definitely this is more important chart, as osimertinib is, despite being a third generation tyrosine kinase inhibitor, is more safe than the other two TKIs. We see skin rash, which was grade 3 and 4 in 0% of patient population in FLORA study. It was especially increased in the with the decametinib, it was 13.7%. With the afatinib, it was 13%. Nail changes, which was present in less than 1% of patient population, it was 2% in the afatinib arm and 7.5% in decometinib arm. And if we see these all, diarrhea and stomatitis were more pronounced with the use of second generation TKIs. And the more important figure is this, the last one. Approximately 5% of patient population requires a dose reduction in the osimertinib due to the side effects. But this data was much higher with the afatinib, where approximately 42% of patient population requires a dose reduction. And this is quite high with the use of decometinib, where approximately 66% of patient population require a dose reduction or continuation of treatment. Next slide. So definitely, if we analyze the sequencing of FLORA study, where crossover was allowed in the control arm, and in patient who failed on the first generation TKIs, approximately 47% crossover was allowed, and they were allowed to get in the test arm where osimertinib was used. So dilemma of sequencing is also resolved by FLORA study, because despite if first generation TKI was used, later we can switch on to osimertinib. This has also shown a better survival rates. Next slide. So the important question is, we always get patients for the second line, because definitely in whom disease is progressing. So if they are started on T7 on the first generation TKI, and if they evolve T790 mutation, approximately only because of deterioration in performance status of patients, approximately 30% of patients are unable to get a second line treatment, despite an evidence to use a second line therapy. Next slide. So we don't have a test which can predict which patient will develop this T790 mutation. So we should try to have this drug as a first choice in all those patients who are random fit for this therapy. Now, whether we have already studied these facts that second line treatment was allowed with osimertinib, and in especially second line in patients who received this drug, 30% of patients in comparative arm couldn't receive a second line treatment because of some reasons that they were having a low average performance status. Next slide. So we are coming to the FLORA 2, which is a phase 3 trial of first-line osimertinib with platinum-based chemotherapy in advanced EGFR-mutated lung cancer patient. Next slide. So in this trial, which is again a phase 3 trial, treatment-naive patients who have exon 19 deletion or L858R mutation were randomized to receive either osimertinib or combination of osimertinib with chemotherapy, platinum combination with pemetrexed, or either osimertinib alone. Next slide. So we do the baseline characteristics, which is quite comparable in the both the arms. Next slide. Next slide. So if we look at this data, the combination of osimertinib and chemotherapy arm, a median PFS benefit was there with the combination of chemotherapy. With the chemotherapy arm, we had a PFS benefit of 25 months, while in osimertinib arm, it was on 16.7 months. If we see the PFS in the patients who have CNS mets at the baseline, the benefit was more pronounced in the patient who have undergone combination with the chemotherapy. In the chemotherapy arm, median PFS was 24.9 months. In the osimertinib, it was 13.8 months. If we see the PFS data, irrespective of the CNS then reviews, then we see that this PFS benefit was renounced in all the cohorts. Next slide. So the investigator concluded the primary end results show that a combination of osimertinib with chemotherapy suggested significantly improved PFS was as compared to the treatment with osimertinib alone. We reported a higher PFS of 25.5 months, and we still are waiting for the OS data. The safety profiles of the combination is quite comparable, and the toxicity is well manageable. So in patients who are having a preserved performance status, especially the young population, combination of osimertinib with platinum and pemetrexed is new treatment option and standard of care in patients who are newly diagnosed with stage 4 EGFR mutated lung cancers. Next slide. So coming to the NCCN guidelines, definitely we have in patient population who have EGFR mutation, we have NCCN as osimertinib as a category 1 recommendation. We have osimertinib in combination with chemotherapy as category 1 recommendation. And lower down in the category, we have the other generation of TKIs, especially elotinib, afatinib, and gapatinib, which are included in the same race. But as per NCCN, preferred choice is osimertinib. Next slide. So I conclude my presentation with the first time with the involvement of this third generation TKI, osimertinib has shown a clear-cut PFS, which has translated into an overall survival benefit. Median PFS reported with the use of osimertinib has a benefit of 18.9 months, and median OS reported is 38.6 months. So we are having patients who can live up to the more than 3 years with this treatment. And the more important fact is that this drug is quite uh, have efficacy in patients with CNS mets. Adverse events are less pronounced as compared to the other TK tyrosine kinase inhibitor, and therefore osimertinib is standard of care in patients harboring EGFR mutations presenting with advanced lung cancer. Thank you.
Thank you so much, Dr. Ankur. For the next talk, I would like to invite Dr. Ulfat Ara.
Thank you, organizers, and thank you, Dr. Ulfit, again for accommodating me in the last moments.
Okay. Good evening, all. Just give me a few minutes. I would like to share my slides if it is possible from my end. Organizers, would you like to please help me? Can you share the slides from your end?
Sure, ma'am, I will share.
Okay. Good evening, everyone. As we are discussing the EGFR mutated non-small cell lung cancer metastatic, here we are going to actually present the exceptional response to osimertinib in patients who are having CNS metastasis. Next slide, please. This is a case presentation of a 64-year-old gentleman who presented with symptoms of cough and progressive breathlessness and severe backache. He could not walk without support, and he had giddiness and a loss of weight, and he was a non-smoker. Next slide, please. Next slide. Next slide, please.
Just a minute.
Okay, it's okay. On evaluation, the PET scan showed a right upper lobe mass, which was 4 cross 3.2 centimeter in size with a SUV max value of 90. And it also showed a multiple this bone metastasis. As we can see, this size of the lesion and then multiple bone metastasis in the PET scan. Next slide, please. Patient was further evaluated. Biopsy was done. It showed adenocarcinoma found to be EGFR exon 19 mutation. Next slide, please. Then this is MRI of the brain, which showed ring-enhancing lesions in the cerebellum and the cerebellar hemispheres, and there was a significant perilesional edema in this patient. Next slide, please. Final diagnosis of this patient was a stage 4 non-small cell lung cancer, adenocarcinoma with exon 19 deletion with bone and brain mets. Next slide. Now, management of this case was, it was actually initially managed with a local treatment in the form of RT, radiation therapy, and followed by the EGFR TKI to the target exon 19 deletion. Next slide, please. As we know that the EGFR-driven, this oncogenic, this is the most common oncogenic driver mutation non-small cell lung cancer, which comprises 15 to 40% of the cases. And we know that the brain mets are very common in EGFR mutated non-small cell lung cancer, which comprises approximately at the presentation 30 to 50% of the cases. In 5 years, EGFR mutated cases will develop brain mets, and some studies have shown the brain mets incidence to be as high as 70% in EGFR mutated non-small cell lung cancer. And we note that the landscape of the treatment of EGFR mutated non-small cell lung cancer has evolved over the years with first, second, and third generation TKIs. And the best PFS we have attained with the third generation TKI, that is the osimertinib. In the FLORA study, the median PFS was 18.9 months. And with the comparator, we know that the second generation TKI, that is dacomitinib, median PFS is 14.7 months. However, in all the generation TKIs, we know that it is the osimertinib which has the highest CNS penetrance rate, highest CNS progression-free survival, and in fact, overall survival as well. Next slide, please. This is the, if you discuss the CNS penetrance rate of the osimertinib as compared to the other generation TKIs, it has the highest attainment of the maximum concentration in the brain, 2.78 micromoles per liter, as compared to the first and second generation TKIs. And the plasma concentration is almost, also high, 0.82, which may be comparable with first generation TKI. But osimertinib, as it is a third generation TKI, irreversible activity, and it overcomes the steric hindrance which is posed by the ATP pocket of the T790 mutation positive patients. So this osimertinib has the highest efficacy, and the best part of it is that it is the TKI with the maximum CNS activity. And we know that the brain to the plasma maximum ratio attained by the osimertinib is also highest 3.41. Next slide, please. This we can see in the, actually, if you consider the imaging, brain imaging, and then the distribution of the osimertinib, we know that the osimertinib rapidly starts, distributing without the brain, throughout the brain in a uniform manner once it is administered. Next slide, please. You know that the best part of the osimertinib drug is that it has the highest CNS penetrance rate, and in patients who have an intact blood-brain barrier, it is the only EGFR TKI which is known to penetrate the CNS. Although we know that in studies which have used the chemotherapy agents like platinums, pramatraxate, carboplatin, they have also shown the CNS activity in some studies as low as 17% response rate with chemo agents, some studies as high as 40%. But we know the best CNS response we attain with the osimertinib, as this drug is able to rapidly uniformly distribute throughout the CNS. Next slide, please. This is the management of a patient when there is an EGFR mutated non-small cell lung cancer patient presenting with CNS mets. The patient can present in two settings, either with a symptomatic CNS met or in asymptomatic CNS met, upfront CNS met or on progression. The patient can present with a CNS met. The dictum is that so far, symptomatic brain mets, which are larger in size and multiple in size, first treatment should be given in the form of local treatment, that is in the form of stereotactic radiosurgery or the surgery, and then followed by adjuvant osimertinib, which is added to the PFS benefit. When the patient has an underlying brain mets as a presentation, but they are asymptomatic, you can go ahead with osimertinib. And same is the case in the patients who have brain progressive disease. They are symptomatic. However, here we have to demonstrate that whether the T790 mutation is positive or T790 mutation is negative. If the T790 mutation is negative, we have to go with the local treatment and we have to continue the TKI, because actually the correlation of T7090 mutation in the plasma and in the CNS, there is a molecular heterogeneity. However, the dynamic monitoring has shown that the mutational burden of EGFR mutation in the plasma and CSF have a high concordance rate, but the T790 mutation shows a molecular heterogeneity between plasma and the CSF. So this recent trials like Bloom and Apollo study, they have actually stressed on the importance of doing T70 mutation analysis from the CSF to demonstrate the efficacy of osimertinib on progression of the patients who have already received the TKI, EGFR TKI, because only those patients who have a CNS progression with T7090 mutation positive and cell-free DNA in the CNS will respond to the osimertinib. Next slide, please. This is again the FLORA trial and the outcomes in the patients who have the brain mets. These two curves are showing clearly the benefit of the osimertinib, irrespective of the fact whether the patient is a known case of CNS mets which has been treated or without CNS mets. Actually, this PFS benefit is slightly higher in patients who are without the CNS mets, which is 19 months. But the patients who are presenting with CNS mets also achieve a very, significant PFS benefit of 15.2 months with osimertinib, as compared to the comparative standard of care that's only 9.6 months. So the patients who present with CNS mets, the drug of choice should be osimertinib. Next slide, please. This is again what the FLORA has shown. Yes, it has compared again the osimertinib versus geftinib and alatinib in the patients who have a baseline asymptomatic CNS mets and the baseline asymptomatic CNS mets determined by the neurological, that is Neurodiagnosis Investigator Central Review. They have actually seen the systemic and the CNS response. If they've seen that the systemic response with osimertinib, the response rate was not reported, and the CNS response rates were as high as 66%. So whether it is the systemic response or it is the CNS response, we know that the osimertinib fares far better than other TKIs. And it has been found that if the patient has systemic response, usually it has a very good concordance with the CNS response as well, almost more than 85%. It's unlikely that a patient who will respond systemically will fail CNS, at the CNS site with osimertinib drug. Next slide, please. If you see from all these trials, all the TKIs, whether dacometinib, afatinib, alatinib, they have not fared superior as far as patients of CNS mets, and most of these trials have not included patients who have baseline CNS mets. We know that for this patient, for bone mets, he received the palliative RT and with bisphosphonates, and for brain mets, first he received the RT and then he received the TKI. The dictum is that we should always, in patients who have large symptomatic mets, go with the local treatment followed by TKIs. Because if you proceed the treatment with TKI like osimertinib and then you follow the RT, or you give concurrent RT with osimertinib, the rate of radionecrosis are very high. So always in patients who have large symptomatic brain mets, we should go ahead with local treatment first, adjuvant osimertinib. And in some trials, they have compared that they have given local RT first and then osimertinib versus brain RT first and followed by SRS. They have compared that the PFS is best with local treatment in the form of RT or SRS followed by adjuvant osimertinib. Next slide, please. So this is again the follow-up PET scan of the same patient in March 2021. We see that there is an appreciable CNS response as well as the systemic response. This is the systemic response. We can see the SUV value has come down from 19 to 3.4. Appreciable reduction in terms of size also from 4 centimeter to max 2.2 centimeters, and the reduction of the nodal size as well. Next slide, please. This is the systemic response we are seeing, and in the next slide, we can discuss that in the patients who are presenting with brain mets, the overall response rates with osimertinib goes as high as 66% in the patients who have CNS full analysis set. That means they have a more than or equal to 1 measurable or non-measurable lesion with a neurodiagnosis support with an independent investigator central view. And for the patients who have CNS available for response, the CNS overall response rate goes as high as 91%. And CNS duration of complete response also is 95%, and median CNS duration of response is not recorded in patients who have CNS full analysis set, and in the available for response rate, it is almost 15.2%. So we can see that in all parameters, as far as brain metastasis, patients with EGFR mutated non-small cell lung cancer, osimertinib is the drug of choice, and it has fared well in all parameters. The CNS, death reduction rate or progression rate with osimertinib is approximately 52%, and the CNS response rate is as high as 70%, and some studies determine that it can go as high as up to 90%. Next slide, please. This is again the follow-up MRI brain. Initially, we saw the PET scan with a good systemic response, and same we are seeing here in the patient. There is a complete response, almost complete response in the patient. If you see the imaging studies of the PET scan, the CNS response is also, fairly good in such patients who actually receive the osimertinib. And it has been seen that the CNS concentration is also high in the patients who achieve response. If you see the CNS penetration rates in the patients who are achieving the radiological response is as high as 36 to 37%. Whereas the patients who are achieving a stable or progressive disease, the CNS penetrance rates and the CNS concentration is only 25%. Next slide, please. This is the follow-up MRI brain. Again, almost complete resolution, which is an excellent response with osimertinib in patients who have presented with brain mets. Next slide, please. Now, these are certain case reports on osimertinib and brain mets. This is a 53-year-old patient who was diagnosed initially with a stage 3A lung carcinoma, and the baseline PET also determined the pretracheal nodal hypermetabolism, and on repeat brain MRI, she was found to have multiple brain mets. So she progressed with the brain CNS disease, and the osimertinib was started at 80 milligram. She actually presented with complaints of ataxia, which was worsening, and she was actually scheduled for surgery in the form of craniotomy with tumor resection. Next slide, please. These are certain case reports which have demonstrated, the excellent and an exceptional response of osimertinib in patients who have presented with brain mets. This patient had multiple brain mets, maximum size 12 mm. It was diagnosed, and after 5 weeks only, they have shown that brain mets disappeared completely together with the response in the lung lesion. This is an excellent response of the patient who has presented with multiple brain mets, maximum size 12 mm, but within 5 weeks, almost complete resolution of the brain mets with osimertinib, which was initially actually planned because of the symptomatic and high burden disease for surgical intervention. Next slide, please. So this is another study which has demonstrated efficacy in CNS mets. This is a phase 2 open level 3 prospective study, and the patients in arm A were treatment naive. Patient in arm B were having EGFR TKI mutated, VT7 mutation positive and negative arm, and they found that osimertinib demonstrated a high efficacy on brain mets. All trial arms displayed a significant decrease in the number and the size of target lesions, and the median PFS, CNS PFS, was almost 11.8 months. Next slide, please. This is again the follow-up PET-CT. We can again see the almost complete resolution of the disease with osimertinib. Next slide, please. And actually the key points, what we take from this presentation is radiotherapy for brain not needed. Still patient had complete resolution, almost complete resolution of the primary, systemic disease in whether it was in the lung or in the nodes and in the CNS as well. No adverse events, and the patient remained progression-free, about 19 months, which is an achievement. Asymptomatic, fully active, and good PFS, good quality of life. Next slide, please. So the key points actually are there are very excellent responses in certain case reports to osimertinib. Such tumors are different or not. We have to go for cell-free DNA analysis of the CSF versus plasma and the dynamic monitoring of the EGFR mutation load in the plasma and the CSF, which is very important. And then we have one more subset, that is the leptomeningeal metastasis, which is also very common in EGFR mutated patients. These patients, one study has shown that if you increase the dose to 160 milligram, they show better response as compared to the patients with CNS parenchymal mets. Even if you increase the dose, they have progressed on osimertinib and you will increase the dose. The PFS is only 2 to 3 months in parenchymal mets progression as compared to patients who have leptomeningeal metastasis. But the CSF concentration and the penetrance is slightly lower in leptomeningeal mets, which is only 16%. So actually, we have to see whether whether in the further studies, as of now, the standard for symptomatic large mets is to go with local treatment followed by osimertinib. But in certain exceptional cases, we have found that it is that patients may respond to the osimertinib, as we saw in the second case, 5 weeks only. And it has been predicted in one study that if there is a dynamic monitoring has shown that the EGFR load in the plasma has almost disappeared within 6 weeks, or some patients within 3 weeks, such patients are going to have a very good response to osimertinib as compared to patients who do not show the EGFR load becoming negative within 6 weeks. Next slide, please. Thank you very much. And thanks a lot for your patience as well.
Thank you so much, Dr. Ulfat ma'am. For the next talk, I would like to invite Dr. Aditya Elhans.
So, hello everyone. Good evening. Am I audible?
Yes, sir.
Sure. So, I'll start with the presentation. So, basically, the purpose of my presentation here was to set stage for what Dr. Ankur and Dr. Bansal have to say in the coming presentations. I've tried to be brief and as practical as possible during the course of this presentation. And the topic today that I'll be covering is overview of lung cancer. So basically, it will be just a revision dose for all of you, since we all are medical oncologists here this evening. So the burden of lung cancer in India, as per Globocon 2020, is that among both sexes and all ages, lung cancer is the fourth most common in incidence. And among the incidents, when we see males of all ages, lung cancer comes out to be second. Although we do understand India has a significant load of patients who are having head and neck malignancies, but still in the Western world, lung cancer can be attributed as the number one cause of cancer-related mortality. So with that in mind, we move to the staging, which very briefly can be said to be for T1 stages, any tumor less than 3 centimeter would be classified as T1. Any tumor greater than 3 but less than 5 centimeter would be T2. Any tumor having size of more than 5 but less than 7 centimeter, along with adjacent involvement or invasion, would be T3. And any tumor with a size greater than 7 centimeters would be T4 lesion. Obviously, this is a very brief definition, does not include all the involvements and invasions. For example, if there is atelectasis, it can be a T2 tumor. And if there is involvement of the mediastinal structures, the tumor can be staged as T4. Apart from that, a very important prognostic as well as predictive factor for staging of lung cancer would be the nodal burden. Nodal burden can be classified as N1 lymph nodes, which can be the intrapulmonary and ipsilateral hilar lymph nodes. N2 lymph nodes can be ipsilateral mediastinal group of lymph nodes. And N3 lymph nodes can be contralateral mediastinal or contralateral intrapulmonary and hilar lymph nodes. So what are the investigative tools that we use for staging of lung cancer? They can be broadly be enumerated as bronchoscopy, contrast-enhanced CT scan of the thorax, uh, 18 fluorodeoxyglucose PET-CT, endobronchial ultrasound or endoscopic ultrasound, a mediastinoscopy, as well as an MRI of the brain. Although we do not utilize all of them irrespective of the stage, we definitely would want to see the patient's logistics factor as well as the disease factor before recommendation of any of the above tests. So what exactly is a CCT versus PET-CT, comparison when we are looking to stage for lung cancer? So basically, we have to keep in mind that any lymph node of greater than 10 millimeter in the short axis has a greater predictability of malignancy. CT scan alone, we know, has a limited role due to low sensitivity of only around 55 to 60% and a low specificity of around 80%. But PET-CT may help in but this may help in selecting appropriate procedures for tissue sampling by providing the images. The addition of PET to CT provides the overall sensitivity of around 80 to 90% and specificity of around 85 to 95%. So why are we doing these things? So there we have to understand that there might be a risk for having a occult N2 disease, which is not actually always detected by imaging, and hence the need for sometimes more invasive staging procedures. In a study by Lee et al., it has been proven now that the occult N2 chances increase when especially there are central tumors, the size of the tumors are greater, and there are strongly FDG-avid tumors on the PET-CT. So certainly these cases do warrant a more enthusiastic, find for higher nodal status. So basically, mediastinal staging can be divided into invasive and non-invasive. Obviously, non-invasive would be the preferred for majority of the centers. We do endoscopic ultrasonography and endobronchial ultrasound for obtaining a biopsy as well as doing a mediastinal staging. And invasive procedures can be briefly stated as mediastinoscopy, which could either be conventional mediastinoscopy or other procedures such as video-assisted thoracoscopic surgery. So basically, mediastinal staging includes this recommended techniques are endobronchial ultrasound and endoscopic ultrasound, which can be non-invasive. And if the clinical suspicion of N2 involvement remains high, even after a negative EBUS or EUS, then surgical staging with mediastinoscopy is recommended. So when exactly should we do an invasive mediastinal staging? So certainly we should consider this in centrally located tumors greater than 3 centimeters, for extensive infiltration of the mediastinum with no evidence of the extrathoracic disease and positive N1, definitely we should go for this indication. If there is a bulky N2 on CT and uh, bulky N2 on CT and there is no need for invasive confirmation by mediastinoscopy or video assisted thoracoscopy. But if there is discrete N2, yes, regardless of the PET-CT result, we should try and do mediastinoscopy. And if normal mediastinum on CT, but positive on PET-CT, certainly we should do. And if normal mediastinum on CT as well as PET-CT, we can forego invasive mediastinal staging. So basically, this is the algorithm that actually summarizes what I have just said. And apart from that, the need for invasive mediastinal staging arises from the basic, deficiency in sensitivity that we have for imaging procedures, as well as endobronchial and endoscopic ultrasound, which are not able to provide a near 100% sensitivity for detection of N2 lymph nodal burden. Definitely video assisted thoracoscopy surgery here scores the maximum with 99% sensitivity for detection of occult N2 burden. After staging the evolution of therapy in lung cancer, this was actually NSCLC was considered as a single disease until the last several decades. And then histologically distinct subtypes came into being, who overall we were able to classify carcinoma, squamous cell carcinoma, and large cell carcinoma to be very different variants, and we could, tailor the treatment requirements for the patient individually. Then came to be the era of molecular oncology, whereby we were able to classify patients using specific receptors and next generation sequencing so that appropriate targeted therapies as well as immunotherapies could be chosen for the patient. And this is not just something that we see on the paper, but it is something that we have actually seen come into reality. There is a trial by in the New England Journal of Medicine in 2022, which stated that lung cancer specific survival actually improved from 26% among men with non-small cell lung cancer that were diagnosed in 2000s to around 35% among those in which it was diagnosed in 2014. So, in the maybe last decade and 2 decades, the survival outcomes have actually considerably improved. And obviously, there is reduction in the incidence along with the treatment advances, particularly approvals for use of the targeted therapies that are now commonplace in our clinical practice. So this is just a timeline that summarizes the various approvals of targeted as well as immunotherapeutic agents for use in non-small cell lung cancer. I need not go into the details of each and every one of them. We'll be discussing a few of them very briefly. Then, as we had molecularly dissected out non-small cell lung cancer, now several guidelines are available that have, treatments for patients. And now at least 12 commonly detected molecular aberrations are being tested in the clinic at majority of the centers. So the current guidelines on neoadjuvant and adjuvant therapy after surgery have largely been dictated by the pathological stage, whereby for all patients with stage 1A, that is N0 and no lymph nodal burden, we had to do just surgery and then just observe the patient. No adjuvant or neoadjuvant chemotherapy was required. For stages 1B and 2A, certainly this needs to be discussed in a multidisciplinary tumor board. And now there is certain data that for stage 2 patients, we might as well choose adjuvant chemotherapy for 4 cycles with a platinum doublet. For stage 2B, it is better defined, and adjuvant chemotherapy for 4 cycles with a platinum doublet is recommended for all patients. And for stage 3 patients, obviously, we can choose going for a new adjuvant chemotherapy followed by surgery, or we can get them done with surgery upfront and then subsequently choose adjuvant chemotherapy. And certainly for a certain subset of patients with N2 lymph nodes, we might as well consider adding adjuvant radiotherapy. Although this is something that can be discussed again in a multidisciplinary tumor board. The other thing is that findings that surgery and surgical resection margins actually affect our adjuvant treatment decisions. So, for example, a stage 1A or 1 or 2A tumor, if completely resected, can be observed, you know, and chemotherapy only for high risk patients is indicated. But if there is a R1 or R2 resection, certainly we need to re-resect these tumor, or maybe refer them to a radiation oncologist for curative radiotherapy. This would be the sequence again for all stage 2B as well as 3 patients. And for all patients, we must keep in mind that if there is a R2 resection, this should be, either re-resected or treated with definitive radiotherapy. So after initial treatment, more than half of the patients with resectable non-small cell lung cancer experience a recurrence within 5 years. So around 40 to 50% remain cancer free, and around 50 to 60% actually have recurred. And this recurrence may be either local or distant. So what the ESMO guidelines state today is that for all tumors with a primary tumor size of greater than 4 centimeters and having a node positivity are now ideal candidates to undergo adjuvant chemotherapy. The understanding that maybe very early on lung cancer can tend to be a systemic disease is very crucial for our patients, and the oncologist must bear this in mind. The benefit that we are talking about with the adjuvant chemotherapy stems from the LACE meta-analysis and several other trials which have shown overall survival benefit from postoperative cisplatin in the early stage non-small cell lung cancer. So LACE meta-analysis was a pooled analysis of 5 trials that evaluated adjuvant cisplatin-based chemotherapy, having a total number of more than 4,000 patients, which mostly utilized cisplatin vinorelbine, but majorly any cisplatin-based third generation doublet was actually allowed. And chemotherapy led to improved overall survival with the absolute benefit of around 3.9% at 3 years and 5.4% at 5 years that we have seen in the LACE meta-analysis. So when we talk about the neoadjuvant or induction chemotherapy, this definitely has role in the locally advanced stage 3 lung cancer patients who can be treated with neoadjuvant chemotherapy. And the trials actually suggest that adjuvant and neoadjuvant are actually, equivalent in terms of the outcomes. Then coming to the uh, trial whereby once we were stuck with adjuvant chemotherapy in our curative settings. So this is a trial by the name of Adura, which has shown that there is improved disease-free survival seen with addition of osimertinib in resected EGFR mutated non-small cell lung cancer post-surgery. So all patients with resected non-small cell lung cancer harboring a EGFR, either a mutation, either an exon 19 deletion or a L858R, and staged 1B to 3A were randomized to osimertinib versus placebo for 3 years. And what we saw was that the DFS actually improved quite a lot. At 2 years, the DFS was 90 versus 44%. So nearly a doubling of the disease-free survival here in the Adora trial that we have observed for this patient subset. And it is now also possible to further improve survival of completely resected stage 1B to 3 lung cancer with who are harboring EGFR mutation. So this was about the patients who underwent surgery and what better could be done for them. With regards to radiation, actually, this as a field itself has actually improved the cure rates as well as control rates and has now emerged as a safe and effective competitor to patients who might not be ideal candidates or actually might have refused to undergo for curative surgery. So, advanced technologies have led to safer treatment outcomes for lung cancer with radiation. I beg your pardon, the slide here suggests 2022 and we are in 2024. So, definitely the technology has improved and intensity modulated radiation therapy IMRT has actually enabled us to do so. So what IMRT actually does is instead of a broad main beams, it actually uses several beamlets which can, configure to the shape and the size of the tumor so well that the tumor can be appropriately irradiated with minimal risk and radiation toxicity to the adjacent normal tissue. Certainly, it is important to differentiate between SBRT and conventionally fractionated IMRT techniques that are currently in play. So SBRT is some nowadays, equivalently proven beneficial for a curative setting when we talk about early stage non-small cell lung cancer. And what this does is use a high dose of radiation per fraction, that is per fitting, typically a 8 to 20 gray per fraction, and usually 1 to 5 fractions are delivered with 3D target localization. SBRT is used in early stage lung cancer, but due to concern of toxicity, it is not usually recommended for larger tumors or patients harboring, extensive nodal burden. We have a 4D CT planning, which allows for margins around a tumor to be minimized. Obviously, image guided RT has been here for almost a decade and a half. And adaptive radiation, which creating a new radiation plan after tumor target volumes have reduced in size. And this is something that now majority of our radiation oncologist colleagues are following. So contemporary RT techniques for stage 3 non-small cell lung cancer can be evaluated. That there was a RTOG trial. Sorry. So there is the RTOG 617 trial that evaluated standard dose versus high dose chemoradiotherapy plus minus cetuximab for stage 3 and stage 3B non-small cell lung cancer. The 5-year overall survival of around 32% with high quality standard dose radiation therapy. And before the era of immunotherapy, this trial was done. So there was no role of radiation dose escalation that was found out in this trial. And obviously, cetuximab added little benefit. So now even better results when immunotherapy has been added to chemoradiotherapy backbone, as we would be coming to in the next few slides. And stage 3 is now a potentially curable tumor. What we used to see that the 5-year overall survival for patients with stage 3 was actually very dismal. Now has actually improved with radiation combined with immunotherapy. So chemotherapy with or without radiotherapy is a standard of care after complete resection of the stage 3 non-small cell lung cancer. And actually, even for patients who have not undergone a resection, this is now a standard that is followed. So the trial in question that we want to discuss is the Pacific trial that was a randomized double-blinded placebo-controlled phase 3 trial for evaluation of durvalumab in unresectable non-small cell lung cancer. For basically stage 3 cancer patients were enrolled for this. And durvalumab actually demonstrated a 42.9% overall survival benefit at 5 years in comparison to the historical OS in unresectable stage 3 non-small cell lung cancer with radiotherapy alone, which was around 15 to 25%. So definitely there has been a considerable overall survival advantage for stage 3 patients when we are utilizing adjuvant durvalumab for patients who are having undergone chemoradiotherapy. So when we look at what is new and upcoming in the this domain with regards to the non-small cell lung cancer patients, so definitely checkpoint inhibition is moving to earlier stages in resectable non-small cell lung cancer as adjuvant as well as neoadjuvant therapy, and there are multiple ongoing trials assessing the adjuvant setting of immunotherapy. Especially the Keynote 091 BR31 with durvalumab, the Envil trial for nivolumab, and the IM Power 101 for atezolizumab. Certainly, upcoming would be the advent of antibody drug conjugate. In the foreseeable future, maybe for HER2 positive non-small cell lung cancer patients, we might be able to utilize TDXD in the coming times, maybe in a year or 2 years or so. So that is something that I wanted to discuss. The key takeaway message would be the management landscape is fast changing. It is actually very difficult to keep pace with all the new recent advances, and such webinars and get-togethers actually help us and motivate us to read in depth about this topic and revise all these things. The newer therapies obviously have a huge potential to improve survival. We have seen addition of osimertinib to resected lung cancer patients, as well as addition of durvalumab for patients who underwent chemoradiotherapy with a curative intent. And both the trials have showed a overall survival advantage. And certainly, pulmonologists need to play a bigger role in the staging of lung cancer, in the earlier detection of lung cancer. Maybe what we see today in the practice is that majority of the patients are actually coming to us with metastatic disease. So maybe, uh, you know, uh, just talking with the pulmonologist and getting them into this tumor board and oncological get-togethers and idea sharing processes is very essential so that we are able to detect non-small cell lung cancer in an earlier stage and actually able to improve cure rates in our country as well. Thank you for your patient listening.
Thank you so much, sir. So, our next talk is sponsored by AstraZeneca. I would like to invite Dr. Abhishek Bansal.
Yeah, good evening, everyone. So, can I have the slides, please?
Sure, sir, I will share. Are the slides visible?
Yes. So, today I'm going to speak on the topic reinventing adjuvant therapy in EGFR mutated early lung cancer. Next slide, please. Coming to the survival outcomes in resectable non-small cell lung cancer needs to be improved. Lung cancer is the leading cause of cancer death, accounting for almost 1.8 million deaths annually. Non-small cell lung cancer represents approximately 80% of all lung cancer diagnoses, with an estimated 30% of patients presenting with resectable disease at diagnosis. And global 5-year-old survival rates in patients with resectable non-small cell lung cancer varies from in stage 1B to 65 to 75% to stage 2 50 to 70% to stage 3A to 30 to 45%. Next slide, please. Testing recommendation in early lung cancer. And you can see that in non-metastatic resectable lung cancer, we do EGFR and PDL1. And if EGFR mutation is positive, either exon 19 or L858R, then we follow the approved treatment recommendation. If EGFR and PDL1 is negative, or EGFR mutation negative or PDL1 is positive, we follow as per the guidelines. Next slide, please. So coming to the current testing and treatment pattern, prevalence of EGFR mutation in resected stage 1 to 3 non-squamous non-small cell lung cancer results from an early EGFR study. Study enrolled consecutively patients with surgically resected pathological stage 1A to 3B non-squamous non-small cell lung cancer between March 2021 and October 2022 at 33 centers across Middle East and Africa, Latin America, and Asia. So this you can see the prevalence. 49% with EGFR mutant were positive, and 19 deletion was the most common. Among them, 50.5% versus 36% of the L858RM, and T790 hump was quite low. And next slide, please. So current testing and treatment pattern, prevalence of EGFR mutation in patients with resected stage 1 to 3 non-squamous non-small cell lung cancer results from an early EGFR study. Treatment pattern, more than two-thirds of these patients underwent only surgical resection. Patients with stage 2-3 non-small cell lung cancer, only 46% received adjuvant systemic therapy. And you can see this. Next slide, please. After initial treatment, more than half of patients with resectable non-small cell lung cancer experienced recurrence within 5 years, which were given surgery, chemotherapy, or RT. 40 to 50% remained cancer-free, 50 to 60% recurred. And it would be a local or a distant recurrence. And given that over half patients recurred after curative intent surgery, there is an unmet need for improved neoadjuvant and adjuvant therapy options in order to improve the outcomes. Next slide, please. So coming to the adjuvant chemotherapy after surgery for stage 1 to 3A non-small cell lung cancer improves overall and disease-free survival by 5% after 5 years. The Anita study. OS, you can see that chemotherapy improved versus the observation, and p-value was significant 0.017, and DFS was also better, in which chemotherapy showed an advantage over the observation. So EGFR TKI in the adjuvant EGFR mutant non-small cell lung cancer setting. Current EGFR TKI evidence has not translated into approval in clinical practice in the adjuvant setting. Either we see the SELECT trial, the stage 1 to 3A EGFR mutant elranatamab after adjuvant chemotherapy RT, 2-year DFS of 88% versus 76% historical control. Radiant trial, stage 1B to 3A EGFR expression amplification erlotinib versus placebo after adjuvant chemotherapy. Clinical meaningful DFS improvement in EGFR mutant subgroup, 46.4 versus 28.5 months. Event stage 3A EGFR mutant erlotinib versus adjuvant chemotherapy, significant DFS improvement 42.4 versus 21 months. And stage 2 to 3A EGFR mutant Jefferson versus adjuvant chemotherapy, significant DFS improvement 28 versus 18 months, no significant OS improvement. And in stage 1B to 3A EGFR unselected Jefferson versus placebo after adjuvant chemotherapy, no DFS or OS advantage. Next slide, please. So current evidence for EGFR TKIs from randomized trial in adjuvant EGFR mutant non-small cell lung cancer setting showed improved DFS but no OS benefit, as discussed in the previous slide. The previous meta-analysis of the 6 randomized trials, there was 48% reduction in the risk of disease recurrence. but the OS was not improved. So adjuvant EGFR TKI versus chemotherapy. Uh, and next slide, please. So why these data have not resulted in a change to clinical practice? They have been limited, the trials have been limited by design, size, and other factors. No OS benefit demonstrated to date. Unclear if adjuvant EGFR TKI therapy results in cure or delays recurrence. No definite evidence on appropriate sequence, drug, or duration of treatment. Next slide, please. ADORA trial, the study design. Patients with completely resected stage 1B, 2, 3A non-small cell lung cancer with or without adjuvant chemotherapy and inclusion criteria of greater than 18 years of age, WHO PS status of 0 to 1 and current non-small cell lung cancer with non-squamous histology and EGF exon 19 deletion or L858R mutation in brain imaging which was negative for brain mets and complete resection with negative margins, maximum interval between surgery and randomization 10 weeks without adjuvant chemotherapy and 26 weeks with adjuvant chemotherapy. It was stratified by stage, EGFR mutant, race, and age. Osimertinib was given versus the placebo, and treatment duration of was 3 years, and treatment continued until disease recurrence, treatment completion, discontinuation, and follow-up was done until recurrence of week 12, week 24, then every 24 weeks to 5 years. Primary endpoint was DFS by investigator assessment in stage 2 to 3A patients. And key secondary endpoints DFS in the overall population, landmark DFS rate, OS, safety, health related quality of life. Next slide, please. The ADORA trial significant improved DFS was demonstrated in primary as well as overall population and stage 2 to 3A osimertinib had a clear-cut advantage arm had over the placebo arm and also on the overall population median DFS was 65.8 versus the placebo 28.1 and the hazard ratio was 0.27. Next slide, please. Adjuvant osimertinib had significantly improved CNFS disease-free survival rate. CNF mets are a poor prognostic factor among patients with non-small cell lung cancer associated with deterioration in quality of life. Improved CNS efficacy with osimertinib treatment. Osimertinib has shown greater penetration of the blood-brain barrier and higher exposure in the brain compared with other EGFR TKIs. Adjuvant osimertinib demonstrated CNS disease-free survival rate benefit versus placebo in both the stage 2 and 1B3A population. ADORA updated CNS disease-free survival analysis showed that uh, osimertinib had a clear-cut uh, CNS disease-free survival advantage over the placebo arm, and median CNS disease was not reached in the osimertinib versus the placebo, and hazard ratio was 0.24. Next slide, please. No new adverse event was noted when compared to primary readout of the ADORA data, and uh, you can see at the time of data cutoff for OS, one additional serious adverse event had been reported which occurred greater than 28 days after treatment discontinuation. Uh, next slide, please. So key takeaway points, in order to improve the survival, we need to put more efforts to identify the lung cancer early. Never miss an opportunity to test for actionable mutation. Now this applies in early lung cancer also, especially for EGFR. Collaboration with multidisciplinary team is key to improve survival. Next slide, please. Key takeaway points, patient may ask for treatment options for best survival probability. Be ready to discuss and offer them as per the best available data. And ADORA gives her probability patients to remain cancer free along with survival benefit. And being cancer free is goal of patients as well as his or her treating physician. Next slide, please. Thank you.
Thank you so much, sir. I would like to thank everyone for